Okay, what is the most appropriate next step in management for this patient? So different types of management. Okay, 43-year-old woman presents to her primary care physician at a 4-month history with a 4-month history, right-sided hearing loss, fullness in the ear, intermittent otorrhea. She has a history of chronic otitis media and eustachian tube dysfunction. Otoscopic examination reveals a retraction pocket filled with white keratin debris in the right tympanic membrane. Audiometry demonstrates conductive hearing loss in the right ear. What is the most? This is probably a piece of cake for you, huh?
Oh yeah.
You're like, oh, I know this. Okay, so these types of questions, let me see. So, okay, hearing loss, fullness. So otorrhea is that like fluid in the ear? Drainage.
Ear drainage.
Okay. History of otitis media, eustachian tube. Okay. Pocket. So you have this white keratin debris, right tympanic membrane. So when I've seen questions with tympanic membrane, usually it has something to do with like otitis media, and then conductive hearing loss. All right. So what do we want to do? Oh man. Okay. Um,
The answer choices here are kind of interesting, but we'll walk through it together. Do you know
okay.
what, by any chance, do you know what the diagnosis is? It's kind of tricky. This is an ENT question for sure, but
Yeah. Not off the top of my head. I mean, I see, the basic ones I've kind of learned about are just like your typical sensory neural hearing loss, your I don't know if I'm saying this right, the Meniere's, which is the
yeah, Meniere's disease. Meniere's disease is usually very specific symptoms of dizziness lasting for a couple hours, right? Associated with hearing loss that's episodic, right? And then having roaring tinnitus along with oral fullness. But this patient doesn't have that. So, not
right,
something and it's usually sensory neural hearing loss that you get with Meniere's. So unlikely that it's Meniere's here.
right. Yeah, I don't see those three. So looking at the answer choices, I don't know if it's A, otolaryngol otolaryngologist. I don't think it's that.
Okay.
No. Um, counsel on the use of over-the-counter decongestion. So with decongestants, I know like if you use them for too long, it can cause like the rebound. Um, like
Yeah, that's
then
good. Do you know what the terminology of that is by any chance? This is
it's
just
like
because we're talking about an ENT question. So
yeah, I think it's like something with medicamentosa, rhinitis
yeah,
medicamentosa.
yep, bingo, good job. So rhinitis medicamentosa. Yeah, good.
But I don't see that she's taking any decongestant. So I don't think you can assume that.
Okay.
And then tympanoplasty. Aren't those like tubes? Like when people are like, oh, I got tubes when I was little. Is that what that is?
Tubes is the correct terminology for tubes is a laryngotomy, which is an incision in the eardrum with tube placement. So a tympanoplasty is different. A tympanoplasty is a reconstruction of the ear with exploration of the middle ear and doing surgery of the middle ear also. So that's what a tympanoplasty is.
Oh, okay. All right. So I would think if you're having debris, I don't know, would it be antibiotics or corticosteroids? Hearing loss. Well, it sounds like an obstructive. So would you want to like remove something? Yeah, I'm kind of stumped on this one.
Okay, what's your gut say?
So my gut is saying I don't know if there's really an infection. It sounds like more of some like obstruction. So if there's an obstruction, what do you do for that? What was, oh man, would you do? Would it, would it be the tympanoplasty? The
Okay.
surgery? I'm not sure.
Okay, let's see. Come on. So it's kind of interesting. So A and D are actually the same answer because you have to refer to an otolaryngologist to do a tympanoplasty, if that makes sense. So
Okay.
so it's you know what I mean. That's why I said it's an interesting question. But let's talk about this. Okay, so what the patient has is a cholesteatoma. Okay, a cholesteatoma is a misnomer. Okay, because it's not a tumor of cholesterol. Just back in the day when someone saw it it looked like a ball of cholesterol because it's white and yellowish. And so they called it cholesteatoma. But actually, under the microscope, it's actually skin debris or keratin debris. So if anything, it should be like a, something with, keratin or something like that, right? But we call it cholesteatoma. But practically, it is keratin debris, right? That is in or on the eardrum or in the middle ear space that causes local destruction. The skin cells cause local destruction and then also can get infected now and then and cause otorrhea or drainage of the ear. So what you really want to do for these is you got to do you got to do surgery, right, to take these out. And I enjoy doing these surgeries, but yeah, you have to kind of do an ear surgery or a tympanoplasty or a tympanomastoid to take this out, and then sometimes you have to reconstruct the ear bones. But yeah, so an ENT has to do this. Kind of interesting question because A and D are practically the same answer, right? Because the treatment is a tympanoplasty, but a tympanoplasty cannot be done unless it's an otolaryngologist. But as a family practitioner, right, you don't really say, hey, I need to refer this patient to have a tympanoplasty, right? You refer them to an ENT, which then the ENT will dictate what surgery they need to be done, if that makes sense.
Okay. Yeah, that makes
Okay.
sense.
So, but yeah, so this, the reason why you get a conductive hearing loss with cholesteatoma is because they do like to erode the eardrum and erode the ossicles of the middle ear, which is what causes your hearing loss. So,
Okay.
steroids and oral antibiotics don't really help here because you don't have an infection or anything like that. Decongestants have nothing to deal with, it can help with maybe temporarily with, for maybe 2 or 3 days to help with eustachian tube, but you're not going to fix the cholesteatoma that way. But yeah, this is kind of a fun question here.